Actually, my presentation is also very similar to the previous one. It's about surgical treatment of Coats disease, and it's an endothelium parasite disease, as you know, and it causes exudative retinal detachment, and we will be dealing with stage 3B detachments. I also do external drainage, but associated with cryo and sometimes laser, and with anti-VEGF or steroids. And this is my technique. This was a 9-month-old boy with stage 3B Coats. You see the drainage. I do the conjunctival peritomy, and you see I do the drainage just behind the muscle insertion area, and from an area where the retina is highly detached, and I put a trocar into the pars plana area. So I give some BSS through that trocar, and when I need it, because I don't put the infusion there routinely, because when I deviate the eye, it may harm the lens. And I drain it again and again while giving some fluid into the vitreous cavity. So you see retina is going backwards with time. And then we can use this trocar for a chandelier and to see if the retina is okay or not. And we can use this chandelier to apply some laser or cryo to the retina. So it's a multi-purpose entry. So as you see here, retina is now almost attached, and then I usually start cryo at this stage. And if I see that retina is in some places, you see telangiectatic vessels which are very crowded, and in the contracted retina, and then you can put some direct laser during the surgery, not indirect but direct laser, just towards the telangiectatic vessels, in addition to this cryotherapy. And at the end of the surgery, this was the post-op 2 months picture. You see retina was attached, and this was 9 months post-op appearance of the same case. So retina stayed attached. This is another case with, again, stage 3B retinal detachment exudative, and this is the post-op appearance. Another case during the surgery, and this is the post-op appearance. So we have, this is the OCT of one of the cases. So we have done this to 5 eyes. With this triple surgery, and we have seen some subretinal fibrosis in 2 of them, probably because of the disease itself, or also it may be also because of the cryo. So combined transscleral subretinal fluid drainage with cryotherapy and intravitreal bevacizumab provides anatomical success of stage 3B Coats disease without the need of vitrectomy in most of the cases. Thank you.
I'd like to congratulate both presenters. I think I published in 2009 online, and then in the BJO, 17 cases done in a similar way. We do the infratemporal modified vertex decompression. We just take off 90% of the scleral thickness in 1 by 1 centimeter scleral window. Transscleral drain, inject Kinacort at the time, 2009. It was like a series of 17 patients with 3 years follow-up. And eventually in 3 to 4 weeks time, after drying up of all the subretinal fluid, we went back doing laser. So I'm glad that 7 years later, these methods proved to be the right way of dealing with Coats, which is an exudative detachment, and it has to be dealt with externally and not internally. I appreciate also the comment that we are not draining retinoblastoma cells. So sometimes the difference is really trivial between an RB case and the Coats case. So if you have 1 in a million doubt, I would prefer enucleating the eye. So this is the other very important message. Otherwise, we will be killing the kid.
Yeah.
if the doubt is put.
Thank you. Yeah.
I'm Sangeet Mittal from India. Just a small comment. I'm doing a similar technique, but I use a Venflon cannula to drain the thing. When you insert this, you can remove the stillet and leave the plastic thing inside, so it's less traumatic to the retina if it touches.
What gauge are you using?
25 gauge.
Yes. There's a very nice poster as well on using 26 gauge angiocath or venous catheter for draining subretinal fluid by Dr. Al Abdullah from Saudi Arabia.
Yeah. Basically, I'm Abdullah Al Abdullah from Saudi Arabia.
Right.
So I totally agree with the method of drainage. However, I'm using AC maintainer in this technique. So even if there is no space in the vitreous to introduce trocar or a needle, so AC maintainer will help to maintain and push the fluid through the cannula. Thank you.
One short question. What is the rationale for anti-VEGF for you? Because these are vessel abnormalities, and there might be controversy about whether they respond to anti-VEGF because we're not dealing with neovascularization. Can you comment on that?
Since these are parasite diseases and since it's just exudation, we know that VEGFs are the most potent vascular permeability agents. Anti-VEGFs may help in that aspect, preventing that vascular permeability. That's the point for me.
Dr. Kaur, do you have any comment on this point?
We do not use anti-VEGF. We prefer to use intravitreal triamcinolone if required. No anti-VEGFs.
If I may have a quick comment on this, it's a form of telangiectasia. So anti-VEGF was found to be useful in macular telangiectasia type 1, and being a form of telangiectasia, this is the initial thought. Back, like 10 years back, the triamcinolone was in vogue, and this is the initial use, I think, in the published paper as well. So it's
Thank you.